I'm going to talk about neuropathological studies in patients with temporal lobe epilepsy. And in fact, I'm not going to show any cutting-edge tools in terms of what you're going to see in this meeting. But I believe, so this is only clinical data, classic neuropathology, and maybe some immunohistochemical studies that has been around for maybe 50 years or more. But I believe that this is very important because at the end of the day, when we are working and studying human diseases, our ultimate goal would be to treat patients. So from the clinics and from the observation from human studies, that we find the questions, the proper questions that experimental data or studies in experimental models could help us to understand the mechanisms and to maybe provide better treatment for these diseases. So I'm going to talk about a very frequent finding that we see in temporal lobe epilepsy patients that are the psychiatric comorbidities, especially depression and psychosis. So this is just the outline. I discuss a little bit about clinical phenomenology of psychiatric comorbidities. For the ones who don't know the natural history of TLE, what we can do with these neuropathological studies, and also discuss some limitations of these studies. So we know for quite a long, since the Greeks, that the association of depression and epilepsy has been actually named by or commented by Hippocrates, who showed that melancholics ordinarily become epileptics, and epileptics melancholic. What determines the differences between when it's from the body, it's epilepsy, when it's from the intelligence or the mind or the spirit, would be a melancholy. So from now on, of course, we know a lot about the relationship between these psychiatric comorbidities and epilepsy. But even in the 19th century and in the probably first half of the 20th century, most people recognized that probably the depression was actually a cause of the burden that the epilepsy could bring to the patient. So the symptoms would be actually a reaction of all the burden like a chronic disease. And that would be affected by this underlying condition. And these events in terms of the epileptic patient are many. So we know that some patients have low self-esteem, they have personal embarrassment with their seizures. Especially here in Brazil, they have lots of difficulty to getting a job. There is still some stigma from the disease. And all this together, of course, would implicate in a depression. But things are sort of changing because especially clinical studies have shown that these are probably extrinsic and intrinsic process that maybe there is a synergistic effect on these conditions. And so this question is more recently, this is a common underlying pathophysiological mechanisms from these two conditions. And I'm going to bring you, I think it's a very elegant study from the group of UK and from Dale Hesthofer. And the motivation of this study was that there was a worry, actually, the FDA issued an alert to the providers, the healthcare providers, warning about the increased risk of suicidal thoughts and behaviors related to anti-epileptic drugs. So patients with epilepsy would be increased risk for suicidal. But the conclusions from these studies came from several studies. Many of them were actually not well controlled. The population of these patients were much more severe. Many patients with temporal lobe epilepsy, for example, and there are some limitations. So probably these conclusions came from conclusions from a selected population of patients. So there were some limitations. So, and there were studies indicating that some patients would have a psychiatric history before the onset of epilepsy. So there was not a direct consequence, but maybe there was some bidirectional effect on these two situations. And so in this premorbid psychiatric disorder may lower the seizure threshold. So that's the question that this study tried to answer. So is there a reciprocal relationship between psychiatric disorders and epilepsy? So they in the UK, you have a huge database from primary healthcare workers, and they provide, actually they have more than 65 million people that have there in their database. And so they try to do a longitudinal cohort study, and taking from this database, from general practice research, so this is a huge data bank that they could actually bring this, or try to answer these questions. So, and they were, the aim was to determine the association between the psychiatric comorbidities in patients with both before and after the diagnosis of epilepsy. So, this is just a summary of the study. They took patients from 10 to 60. From the epilepsy group, the definition of epilepsy is that at least the medical code epilepsy, and the patients would take at least 2 anti-epileptic drugs prescribed during the study. And for each patient, they have 4 controls that were matched to age, index, date, sex, and all other demographical data. So the study period, they look at 3 years before, then they have the index, the situation, and then 3 years after that. And they look for depression, anxiety, substance abuse, and independence, and suicidality and psychosis, like bipolar disorders, reactive psychosis, and non-organic psychosis. So the number of, in the epilepsy group is almost 4,000 people and over 1,400 in the control group. And they, as you see here, the age of the study, the gender, median follow-up for before and after, they're actually identical. And here we have the data. And as you see, this data is presented as index rate ratio in terms that the incidence or the prevalence of these symptoms were compared to controls. So if it is, they have the same frequency, they would have like around here. So this means that, for example, for psychosis, that the before and after, all of the patients, epileptic patients, all have a index ratio, rate ratio, much above the control situation. So from 16 up to maybe 3 times more. And this is the 95 confidence interval. So there is no doubt that before epilepsy and after that, the condition is the epilepsy, the condition did not worse. Actually, the patients were with the incidence of psychosis is much more greater even before the epilepsy, the condition. So for depression, the same, and they're all from the 3 years before and 3 years after that, it's the same. For substance abuse, actually, just at the end of the 3rd year of already having epilepsy, there is a decrease. And if we go to incidence ratio and prevalence ratio of suicidality, we know that it happens in the same way. So the conclusion of this study is that probably the first big cohort study to demonstrate the two-way relationship between a broad spectrum of psychiatric disorders and epilepsy. And then, probably the psychiatric disorders are both associated with increased risk of developing epilepsy, and following the diagnosis of epilepsy, the risk of developing psychiatric disorders is also increased. Then this actually suggests that there we might have a common underlying pathophysiological mechanisms that are present and that could lower seizure threshold and increase risk for psychiatric disorders and suicidality. So I think that this is very important because at least for the providers and for the clinicians, we know that all epileptic patients, they use anti-epileptic drugs. But this is not, actually, we have to face this as a bidirectional event, and there is not a causal relationship that would be, that previously many researchers would talk about it. And so this phenomenology is similar to depression when it's pure depression or associated with epilepsy. We know that this prevalence is very high on patients with recurrent seizures. They range from 20 to 80%, especially in temporal lobe epilepsy patients. We see it very frequently. And the most frequent symptoms include feelings of anhedonia, guilty, and suicidal ideation. And it's similar to what we see in depression. But other authors also report that there are some anxiety, hostility, feelings of dispersonalization, and we know that depressive psychotic manifestations is less frequent. Usually, the depression symptoms is milder than pure depression or major depression conditions. But the source is actually there are significant disruption of the patients. They have really harm for their daily activities, and most of them actually, all of them, they need to go to the same medications that we use for pure major depression. And these depressive symptoms, they can occur around the seizure period or to be interictal. That is more frequent when it is interictal. And so in temporal lobe epilepsy, these comorbidities are much more frequent. For the ones who don't know the natural history of these patients, usually these patients, they have a history of an initial precipitating event that usually occur in the first years of life, usually a febrile convulsion that is prolonged. Then they start to have these cognitive seizures that in the past we named it complex partial seizures. Usually it happens at the end of the first decade or the second decade of life. The seizures are like this one. The patient that have a behavioral arrest, does not contact with other persons, and start with some oral automatisms. Patients don't remember what happened, so despite the fact that many of the seizures does not generalize, they are very, there is a big burden of morbidity in these seizures. Usually they respond to antiepileptic drugs at the beginning, but they become pharmacoresistance for some control. And we know that we have a very, very good outcome with surgical resection. And what we see in imaging studies is this atrophy, and we also see signal changes in other sequences like FLAIR and T2 sequence imagings. And we know that especially the hippocampus is very atrophic when we have several neuropathological changes on that. And this is actually not here in Ribeirão Preto, but I think in the most epilepsy centers around the globe. This is the most frequent partial focal epilepsy in adults. Here we have the distribution of the most common etiologies, and we see from our surgical center, from resections in adults for over 1,100 patients since we have in '94 we started. More than 2/3 of these patients they have mesial temporal lobe epilepsy, and actually this is more than all other etiologies together. And we know that we have epidemiological studies that relate temporal lobe epilepsy and psychosis, and we know that this is particularly associated with schizophrenia-like psychotic episodes. And we know from studies from the 80s that these patients have higher rates of psychosis than the general population, and even the population of epileptic patients without temporal lobe epilepsy, so other types of epilepsy. It's considered that there are some difference from true schizophrenia. We know that it's a mild form of a psychotic condition. And we know that in the studies from the 70s, there was actually a belief that this would be correlated with neocortical lesions, not mesial ones. But this is, I think, a finding that was disproved with more recent studies, especially from epilepsy surgery centers. So at that time, there was a belief that probably neocortical lesions, especially in the left temporal lobe, would be related to these psychotic symptoms. But at that time, only a limited number of studies attempt to correlate these schizophrenia-like psychosis with some neuropathological or physiological parameters. So the phenomenology is a little, there is some differences. Generally, these patients, they lack a schizoid primordial personality. Generally, the affect, the mood is preserved on temporal lobe patients. And we know from several reports that there is a common religious coloring and some paranoid ideas. And usually the prognosis is better than we see in schizophrenia from especially young patients that could evolve to a hyperphrenic state. So there are some differences. And also we have less evidence of a genetic predisposition in this subgroup of epileptic patients. So as I said, the natural history of epilepsy, we have this initial precipitating injury. Usually there are different, but mostly febrile seizures that are prolonged. And after that, we know that patients, they recover, they may not, seizures may not recur, but when they start having these cognitive seizures or complex partial seizures and they become pharmacoresistant, we have a chance to do a resection of the mesial structures, and when we have the material to study is the specimens that usually we have part of the amygdala and the head and the body of the hippocampus is removed in an end block. So we have a chance to do all kinds of studies. Some of groups, they do electrophysiological studies when the tissue is still alive. But here we have a chance to do molecular studies, immunochemical studies, and quantify all the parameters that are associated with this hippocampal sclerosis. And so we have the opportunity here to see if there are differences between patients with different spectrum of the temporal lobe epilepsy and with and without comorbidities. And this, the literature that, the studies that have been addressed several changes, neuropathological changes that are related to neuron dropout or plastic changes after we have the cell damage, and also non-cellular changes that we might occur, like extracellular matrix proteins, inflammatory response. But it's a huge amount of data. There is a huge amount of data addressing all these changes. But I'm going to focus on three very important parameters that are related to neuron degeneration and also changes in neuronal circuitry and the trophins or the trophic factors that are related to the plastic changes and to the reorganization of the tissue after a damage. So what I'm going to show, actually this is, we know that there are several changes that occur in the sclerotic hippocampus. So this is a technique that several groups use to show that patients with hippocampal sclerosis, they have a reorganized circuitry, especially in the fascia dentata. Here is the granular cell layer, and this technique we use to identify that the synapses that are rich in zinc, it is the TIM staining, and we see here in the control hippocampus from autopsy patients that these projections are mainly restricted to the hilar region and the CA3 region, and here we have abnormal staining in the inner and outer molecular layer, meaning that probably there is a growth or a sprouting of collateral axons that project to the own dendritic field. So this is what we call mossy fiber sprouting, and usually we see it in most of the patients with mesiotemporal lobe epilepsy. And we are also going to address some neurotrophins that promote this sprouting, and this has been described in different animal models in vitro as well. So the questions that we want to raise with this is this possible to distinguish structural and molecular changes in hippocampus of mesiotemporal lobe epilepsy patients with and without psychiatric comorbidities? And are these structural changes associated with specific behavioral states? So most of the study I'm going to present now is from Ludmila. She's in the audience. At the time he took that picture, she was blonde. Now, thinks that her hair is sort of reddish, but it happens with women. But this is a study that she did when she was doing her PhD with me, with our group, and she tried to look at with the hippocampus from patients with no history of psychiatric disorder, interictal psychosis, major depression, and compare to controls and see if there were differences in cell density and neotim staining. And this is, I don't know if you can read it from there, but there are several demographic data that are very similar between groups. But here we know that this is the mean age with seizures became recurrent. And we know that the patients with psychosis, they start having their recurrent seizures later. And also, we saw that patients with depression and psychosis, usually they have more secondary generalized seizures. And also, when we look at some memory in verbal tasks, we notice that patients with psychosis, they have a poor memory verbal scores when compared to depressive or patients without psychiatric comorbidities. So the conclusion that patients with psychosis develop recurrent seizures later than the other groups. Generalized seizures were more frequent in patients with these psychiatric comorbidities, and patients with psychosis had the poorest performance in memory tests. When we look at the pattern of cell loss or pattern of cell density, we notice that is in several hippocampal subfields, it is very similar to what we see in typical MTLE without comorbidity. But we notice that in CA4, this group are more preserved, the depression group, and also here we notice that there is some difference between these two groups and controls. So the pattern of cell loss is very similar to among TLE groups in the majority of hippocampal subfields, but the CA4 subfield is more preserved in depressive patients, and patients with TLE and psychosis have lower neuronal density in the entorhinal cortex. When we look at the intensity of TIM staining, we saw that the depressive patients, they have a larger sprouting, especially when compared to the psychotic group. So the psychotic group presented a lower mossy fiber sprouting than the TLE group and the depressive group. And this group, the depressive, they have the most impressive mossy fiber sprouting. When we correlate with some clinical variables, we notice that a higher proportion of TLE patients with depression and with psychosis present these secondary generalized seizures. These patients with psychosis had a poorer performance in the memory tests. And depressive patients and patients without psychiatric comorbidities, they have a similar performance in many of the tasks. So when we look at, this is a study that came out in Journal Neuropathological Experimental Neurology, and we look at actually to the neurotrophins related to the same syndrome. The series is not exactly the same. There are some overlapping patients, but we also had 4 groups, actually, patients without history of psychiatric disorder, patients with interictal psychosis, depression, and a non-epileptic controls. And we also did neuroteams, NeuN, and neurotrophins for NGF, BDNF, and N33 to see all these changes. So when we look at the demographic and clinical data, many of them there were no difference, but we, as in the previous study, we noticed that there was a trend to have higher secondary generalized seizures in both groups, psychosis and depression. And also the memory performance is worse in the psychotic group. So this clinical variables, other clinical variables were not different. So regarding neuron densities, the pattern of cell loss is typical in MTLE groups when compared to autopsy controls. And when we look at the mossy fiber sprouting, we saw the same effect in a different series. So the results were the same in the previous study. And what we saw in the clinical relevant variables, that neuronal density correlated inversely with seizure frequency in CA4, prosubiculum, subiculum, and parasubiculum. It means that the greater the cell loss, the greater the cell loss, the increase the seizure frequency. So neuronal density is lower when the patients will have a great seizure frequency. So the scores also correlated with seizure frequency, the mossy fiber sprouting scores. We have several experimental data that have also shown that result in animals. And the dispersion also correlated inversely with CA4 density. So these findings are associated with both brain damage, induced plasticity, and this indicates that probably the changes are related to excitability states. So we didn't see no difference between mossy fiber sprouting or neuron density, especially when patients were taking or not fluoxetine. But we found that patients that were taking haloperidol had decreased neuronal density compared to not taking haloperidol. So when we look at the immunoreactivity, some changes, actually the most robust changes we see in the glandular cellular layer, some of them are sort of difficult to analyze because there are several subfields that are, we have a neuron dropout very intense in some subfields. But in the glandular cell layer, we know that patients with MTLE have greater expression of NGF immunoreactivity. Here we see that patients without comorbidity, with depression, and with psychosis, we see that the expression is close to controls, but still above in most of the subfields, but especially in the fascia dentata. So this immunoreactivity correlates with mossy fiber sprouting, gray value, that probably there is a relationship between dystrophic NGF immunoreactivity and the sprouting, and seizure frequency. No difference between NGF immunoreactivity, no difference were seen in depressive patients taking fluoxetine or not. This is a drug that we commonly use in these depressive patients. And patients with psychosis taking Haldol showed less immunoreactivity in NGF, also in parasubiculum. And considering the seizure type, patients with secondary generalized seizures exhibit decreased values versus those with only a complex partial seizures in the hilar region. For BDNF, we know also that changes are mainly related to an imbalance between cell loss and expression of these proteins in neurons. But when we look at this data, we saw that brain-derived neurotrophic factor, this immunoactivity, correlate positively with neuronal density in hilar CA3 subiculum, but not with mossy fiber sprouting dispersion in the granular layer. We saw that the greater BDNF immunoreactivity in CA1 when we compare patients with and patients that were not taking fluoxetine. And patients with psychosis taking haloperidol show decreased BDNF immunoreactivity in the hilar versus those who were not taking haloperidol. And the changes were more impressive in the granular layer, and the other regions the differences were not impressive. For NT3 immunoreactivity, we see that the changes are not but different. We don't know if the antibody is not good, but autopsy and epileptic patients, they have no different. Usually we have a faint and strong to NT3, especially in the blood vessels. And we didn't see differences in immunoactivity area among the groups. So we know that we have some limitations with neuropathological studies, and I'm going to show you a picture here that probably the old ones in the audience would recognize that, probably Roberto and Vita. So it's like the hippocampal sclerosis is like a late picture of a long history. So this is I don't know if the young ones know about this figure, but this is a first version of the Planet of Apes. And I remember that I was a kid, actually, was trying to watch a movie that was, here in Brazil, was PG-14, and I succeeded. But there was a movie that the astronauts, they traveled in the space. It's the same story that you have in the newer version. And so they came to a planet that was dominated by apes, and the astronauts were struggling to survive. But at the end of the movie, we see that the story is that actually was the Earth. They just traveled in the future, and this was the Liberty statue, and this is the astronaut and his girlfriend. So this is actually, the hippocampal sclerosis alone, actually, we don't know, but there are many things that happen during the story. So usually we have this injury that happens early in life. These cognitive seizures usually occur by the end of the first decade of life. Then they have anti-epileptic drugs. They're different. They get pharmacoresistance, and they use other drugs to treat the comorbidities. Usually the temporal lobectomy is usually performed in a late stage of the treatment. So there are many pathological changes. We don't know which are the causal ones and which are merely epiphenomena or compensatory changes. There are some other limitations. We are just looking at one region, especially for the comorbidities, and we are going to learn in this workshop there are many other regions, especially in the prefrontal cortex and frontal lobe, that are related to these comorbidities. So if we're going to study only the hippocampus, we will not have a complete picture of these disorders. Probably this is very important for the epileptic condition, but the psychiatric comorbidity is much broader picture. So then we know that we need prospective, especially neuroimaging studies that are necessary to establish even a causal or association, a strong association between these structural changes and the behavioral function. So the conclusion, I think that we provide some demonstration that we have differential neurotrophin expression in hippocampal formation in patients with and without this psychiatric comorbidities, supporting the association between the mossy fiber sprouting and the neurotrophins. There was an association between the use of some antipsychotic drugs to increase neuronal loss and decreased neurotrophin expression. We don't know if it's causal effect. And we know that there is a high prevalence that psychiatric symptoms in patients indicate that probably we have shared mechanisms that are shared in these two conditions. This is a dysfunction of the limbic circuitry as a whole. Actually, this is a limitation that due to the characteristics of neuropathological study, it was not possible to define the exact variable that might contribute to the genesis or maintenance of this particular comorbidity. So we also acknowledge that studying only the hippocampus will not lead to a complete understanding of epilepsy and related psychiatric disorders, even in MTLE patients. But these, at least, we know that we can, with studying the hippocampi from patients with temporal lobe epilepsy, we believe that it's a unique opportunity to examine the neuropathological, the biochemical changes, and relate these comorbid psychiatric symptoms with this chronic epilepsy. I think this is the last slide. I just like to thank you for your attention, and also thank for all the students, friends, collaborators that have been working with us in this several years. Thank you.